Hello there. Abdurrahman here, and this is our next video on biostatistics. And in this series, um, we are focusing on biostatistics since it's really, really hard and not really actually hard, but it's annoying for students, and a lot of people have problems with it. So hopefully, I can cover as much as I can on it and help you guys out. So, and also, if you have like any recommendations, any questions, please feel free to comment down there and make sure I read them and do videos on anything you guys have problems with. Also, subscribe, like, yeah, and all the cliches. Let's get this out of the way. So, yeah, and also if you have like any advices, any recommendations for or any feedback from the videos, please feel free to comment. So let's start. Today, our video is going to be about also try and keep it as short as I can. So this video is going to be on study types and how to solve questions on them. But basically, by the way, my style on these videos is consists of two things mainly. And actually, I think this is like my go-to style and my perfect plan to go through USMLE if you're still going through them. So it's basically you need two things. You need the concept in your head, and also you need to apply it. Because sometimes people really memorize first aid, memorize all of this stuff, and still can't apply it. So you need both things. Both are very, very important. So and that's actually what we're going to focus on today. We're going to at first do a bit of recap on the concept, and then we'll apply it to a lot of questions. So, by the way, I'll make some timestamps, so feel free to go through the questions if you want. If you want like to listen to the recap, feel free. So, let's start. Today we're going to start with the study types, and yeah. So basically, we have like some general scheme first. And this general scheme, I'll use like the first slide actually to do it, and I'll ruin it for you, but yeah. So we have two main study types, by the way. We have observational studies, and we have some interventional studies. And from its name, I think it's obvious. So the observation, you just make an observation. That's it. You observe, nothing more. You don't intervene. That's the main stuff. So, intervention, from its name, you intervene. And what they mean by intervene, it's basically any kind of modification. I'll tell you an example to make sure you get this right. So, as an example, if a patient, if you're studying a patient for blood pressure, and this patient is already on drugs, and you're just observing the drugs and how will they affect the patient. So you're just observing, and you will not add any drug. You will not add any dose. You will not set anything. You're just observing from outside. Still, you are observing. That's it. So, by the way, some people think that observational is just like cross-sectional studies and all of the stuff that you're just asking questions. No, it's not about that actually. It's any kind of observation whatsoever. So, as an example, if you're observing the effects of some drug, that's observation. If you're observing the effects of some pharmaceutical stuff, if you're observing some effects of on cancer, if you're affecting rare disease, all of these are under the umbrella of observing. So that's it. So it's not necessarily just away from drugs. No, you can observe drugs from outside as long as you don't intervene and don't change anything. Just observation. That's it. But intervention, on the other hand, it's yeah, it's intervention. And by intervention, we mean you modify. You're not just sitting there watching. No, now you're taking an action. You're taking a part of the events. So, as an example, if you're trying to study the effects of blood pressure medication, okay, I'll get two groups. One group I'll give it a drug, and the other group I'll it would be like a placebo group, taking just a placebo medication or like a sugar pill, not really something. So yeah, and by the drug group, I'll give them a drug, and also I'll assign the dose, and I'll assign when they will take it, uh, uh, um, how often will they take it. So I am modifying everything. I'm not leaving anything for chance. No, I'm controlling everything. That's why they call it controlled trials. It's not really important now, just to, this is just like a general scheme of things. And by the way, observational studies, sometimes it's just pure observational. That's it. And sometimes it's analytical. And by analytical, we mean you do some relationships. So sometimes you're just observing and not getting any relations out of the way. And sometimes you're analyzing the data from the observation and seeing some relations there. By the way, also, um, the idea about observational intervention, these things, usually what happens is you don't really, because, by the way, trials are very, very expensive. And to get into an interventional study, it's very, very expensive. It's time consuming, it's resources consuming, it's human consuming, even. It can be dangerous. So, what we want to do is we want to limit our losses. So what we will do is we will do an observational study because it's easy, feasible. Sometimes it's done even online without uh, um, um, without having to get into like the situation or get offline and consume time and effort and all of these stuff. So sometimes it's very easy observational studies, yeah, and they are easier to make, very fast to make. So that's it. The way to go is first to observe and see if there could be a relation, and then going into intervention. That's it. So that's the way of things. So after this scheme of things, let's now get into the details. So observation study. Let's start. We have four of them here. By the way, first aid added other stuff that I will not discuss because I really don't like first aid adding extra stuff. What I'm focusing about here, or my top priority is the NBME concepts. That's it. Not going to take other stuff. So yeah, let's start with the first one. We have case series and also case report. I don't know why first they didn't write it, but usually, yeah, as an example. Coronavirus, as an example, it's a new virus. It's a new a new virus here. So we did not know here it exists, or any other disease that's still new. We don't know its effects. How does it happen? How could we treat it? And how does it affect the patients? So, if we saw something new, something weird, something that was not reported before, now we can report it. And we report it in two ways, actually. It depends on how many patients you have. So if you have just one patient or two patients, you can do a case report on it. That's it. So case report, it's like small amount of patients that shows new facts or new effects. As an example, also, if you are developing a new drug, and this drug you're not really sure about the long-term side effects, so you observed a new things or a new side effect um, happening with this drug. So it's weird. It's not been reported before. So you will make a case report about it. That's it. Um, but the difference between case report and case series again is how many patients you have. So case report, it's small amount, like one, two, three. That's it. Case series, no, it's more than that. It's from four to above four. Yeah. And again, what will you do on these two study types is just reporting, mere reporting, nothing more. That's it. These are the ones that you're just observing. There's and just describing, by the way. It's also called descriptional. You're just describing. Yeah, you will describe as hard and as much as you can, but you will not intervene. Of course, it's not interventional. You will just observe and describe. That's it, nothing more, because you will not make relations. You're not comparing. So yeah, and also yeah, so you're just describing like several individual patients with same diagnosis, treatment, and outcome, and reporting the new stuff. That's it. And description of like of the clinical findings and symptoms. There is no comparison group, and also you're not showing any risk factors or any relations or associations. Again, it's not analytical. No relations. Yeah, that's it. These are the two descriptional studies. Let's now get into the analytical ones, the ones that make relations. We'll start with the first one, and the most famous one actually. Anybody like starts researching, probably started with a cross-sectional study because it's very famous. It's very easy to make. Just a survey, and we're done. So a cross-sectional study, it's studying with a larger scale on a very like more people definitely can do it like on a scale of a state or a scale of a country as an example, or a scale of like a school, a hospital. So you're doing a cross-sectional study. And in the cross-sectional studies, what you're doing is you're doing like a survey to ask some questions, but these questions really give you a couple of like a detail, a lot of details actually, not a couple of details. As an example, you will do a cross-sectional study to study the relation between depression and using drugs. So, what I found out is I took some patients, like just a random sample, by the way. Most of them, you take a random sample. Sometimes not random, but usually it's better to be random to get more accurate details about population. So a random sample, and you study the relationship between, if there is a relation, we're not knowing yet. So to study if there is a relation between depression and using drugs. So I'll get a survey and ask the patients, are you showing some depression symptoms like low mood, low affect, um, low concentration, and the other symptoms famous for depression? So I'll ask about the depression symptoms. Okay. And also I'll ask some questions about drug usage. So they are targeted questions. You're not really asking random questions. No, it's targeted questions depending on what are you looking for. That's it, because you're looking for a relation. Again, that's it. So you're looking for the relation between depression and using drugs. So um, let's assume we found a relation that a lot of patients with depression really did use drugs at a certain point of life or are currently using drugs. So okay, we know there's something going on here. We're not knowing really what's going on, but there's something here. And this tells us, by the way, also we can study like how many patients are having the disease or having the depression. So it studies the disease prevalence. Again, we can like take a random sample from the population and see if they have a depression. And if they show more depression, this means there is more prevalence of depression. So it studies the prevalence. How many patients having depression? That's it. And also, I'm seeing what's the relation between depression and using drugs. So you're seeing the associations or the risk factors. Is the drug usage really a risk factor or not? And if I found a relation, again, I'm not saying that it's a causal relation because we don't know. Like, is depression really caused by drugs directly or not? Because the thing is, sometimes, not sometimes, a lot of times, there can be a confounding stuff. We'll talk about biases in another video, but um, the thing about confounding is, I'll tell you an example. Usually, and I'm a little bit judgy here, but that's how things go. Usually, people who use drugs extensively, of course, usually have financial problems, usually have personal problems, relation problems, or familial problems. So they have psychological issues on the background and also like life issues. So there is a lot of other issues than drugs. So drugs can be a cause of personal issues, and the personal issues cause the depression. Again, so drugs here, depression here, and personal issues here. So drugs isn't directly associated with depression. No, it's associated with personal, and personal issues has the relation to depression. It's just an idea. So it's not a causal relationship. No, it can be just an association or an indirect relationship. He, um, um, yeah, so that's what I meant there. It's not a causal relationship. No, it's just an association. And then after we found this association, we'll study it more to see what's going on there. That's it. So that's all about cross-sectional study. You study the frequency of the disease and frequency of risk factor. How many patients are having depression and how many patients having depression are using drugs. That's it. So, and also the main question here is that you're asking what is happening. That's it. Let's now move on to the next type of study. And the next one is, let's just move these out of the way. So, yeah. Let's now move on to the next one. And this one is case control studies. So, usually we study case control and cohort together because they're like a opposite to each other. So, the thing is, now after I found some relation, I'm not sure yet. I'm going to study the risk factors more and the code and the relationships more. So I'm trying to see an to do an observational study in order to better examine and to examine the relationship more. So we have two ways actually. That's it. Two ways because yeah. So and the ways are you can start by getting some patients with the disease or with like the depression as an example. Let's play with our example. You will get some patient with depression and some patient with no depression, plus no depression here. Yeah, to compare each other. And you can start by the patients already have the disease, so one is diseased and one not diseased to compare. And you can go back in time to see if this patient really did take drugs or not. So was he exposed to the risk factor or not? So you can at first this is the first idea. You can start by disease patients and see if they have the risk factors or not. And you go back in time to see the risk factors in order because if we found that that all of the disease patients had a past issue with drugs, then there is really a causal relationship going on here. It's the relationship is very very strong. Not causal, really, but the association is very strong. Then this is a major thing. We have to better examine it more. Yeah, that's it. That's the first way to go. Or there's another way. You can start by risk factors. So you can start by getting some patients using drugs and some patients not using drugs and move forward in time and see will they develop depression or not. So this time you started by risk factors in order to see will they have the disease or not. That's it. So these are the two ways in order to study the relationship between risk factors and diseases. You either start by diseases and see by going back in time to see the risk factor was there or not, or you can use the risk factors in order to go forward to see will they develop the disease or not. That's it. And the first one, where you start with a disease and go back in time to see that the risk factor is case control studies. And the other study that study type that uses at first or starts by the risk factors and going forward to see will they develop the disease or not is called cohort studies. That's it. Hopefully it makes sense. And I'll also make give you just a quick recap again. So case control, you study by the you start by the disease. This is the present, by the way. This is past, and this is future. So you start by the disease, You get some patients with the disease, some patients without the disease in order to compare, and then you go back in time to see were they affected to the risk factors or not. That's it. So to compare risk factor frequency and to see is there a strong relationship or not. And strong relationship for this like a relation you study by something called odds ratio. That's it. So odds ratio, that's your way to study these things and to study the relation and the trends of the relation. Because you're asking the question of what's the odds? What's the odds of these disease patients or these depressed patients taking drugs in the past or having some issues of drug? What's the odds of that? So that's the main question here. Make sure you also know odds ratio. If you see it in the question, go ahead and choose something related to case control. That's it. Also, by the way, another thing that we will discuss this again in biases, but the thing about case controls, why there is some problems related, and this is you go back in time, so you use the memory of patients. Sometimes it's not really a good thing. Sometimes you not don't use the memory, you use some electronic records or records of the patient, which is better, yeah. But again, memory is not really the most accurate thing. So sometimes it can throw you around. So that's it. That's case controls. Let's now move on to the cohort. And yeah, again, it's the same idea as we discussed. You start by the risk factors and then seeing will they develop the disease or not. So we're starting by one having risk factor and one not having risk factor. And then moving forward in order to see will they develop the disease or not. But yeah, here it's a little bit tricky because they differentiate between retrospective cohort and prospective cohort. And I know for sure that a lot of a lot of students have problems with this. Yeah, I know. Because I did so actually. But it's actually very simple. So both of them actually the same. You move forward. The arrow goes forward. But it depends on when did you start. So if you started in the present, at the present moment, so you're moving forward from the present moment, so you're moving to the future. As an example, if I started with patients doing drugs right now, and to see the depression, will they develop depression or not? So I'll move forward with them in the future, in like the upcoming month or the upcoming year, to see will they develop depression or not. That's prospective cohort. That's it. So you start at the present and you go to the future. That's it. Moving forward. That's it. And you compare, by the way, disease incidence, because you're asking the questions: will they develop the disease or not? By the way, incidence equals new cases. You're studying the incidence. How many new cases developed? Or what's the or how often? That's actually more accurate. How often new cases develop? That's it. So it's actually calculated as new cases over the population at risk. That's it. So new cases over population at risk. That's it. That's prospective cohort. Next is retrospective cohort. Now you're starting actually at the past. So what happens is you start at the best. You start at okay, I have two electronic records of one patient exposed to drugs and one not exposed to drugs. So you're starting with the risk factor again, and then moving to the present and following the records to see will they develop the disease or not. So you compare the disease incidence, but this time you don't move to the future. No, you're just actually starting from the past and moving to our present moment by reviewing, of course, the previous records. And the difference is actually like in real life, we tend to use retrospective sometimes when the study is rare, like a rare disease as an example, or a rare risk factor, because you're focused on the risk factor. So a real risk factor that will not recur again. So you don't really have any data. So you have to make some amends and do some compromises and like use the retrospective to save more time. because it's already records. It's already there. You're not going to waste more time. Prospective usually takes like a couple of years of follow up. That's it. So it's actually a lot harder. That's it. Cross section, of course, you are seeing the how much risk factor and how much disease, and also you're comparing the disease prevalence, all at the present moment. By the way, cross section happens at one moment, like at the moment you started seeing patients. That's the moment you will compare, or the moment you will measure the frequency or the prevalence. So it's like a snapshot of the population, snapshot, a camera shot of the population. You're seeing, do they have a risk factor? Do they have a disease? Actually, picture it as like a photo. So risk factor is here and the disease is here, and you're seeing, okay, there's a lot of risk factors and lots of disease. Maybe there is some association. That's the cross section actually. That's it. Let's now recap it from here again, just to cover them again. So cohort, yeah, case control, it's retrospectively comparing groups of people with the disease. You start with the disease to see, are they exposed, were they exposed to risk factors or not. So you're also asking what happened in the past, by the way, and you measure the odds ratio. By the way, you depend on that memory. Sometimes it's bad because, by the way, I'll tell you something. Sometimes when you start with the disease patients, let's use our example. So you will start with like the depressed patient and the non-depressed patient. So more disease patients actually tend to say that they were exposed more to drugs. That's the thing. Also, another example. Let's imagine one heart failure patients and one normal patients. So the heart failure patient will tend to tell you or remember that he was exposed more to like anthracyclines as an example. So yeah, that's the thing. Memory is really a selective thing. That's the bad thing about it. So it's selective. So you're remembering more. That's the recall bias, by the way. That's it. That's case control. Cohort, no, you're starting with the risk factor and moving forward to see will they develop the disease or not. So, um, uh, yeah. So you start with the risk factor again, one a group with risk factor and one was not. So and to see will they develop the disease or not. It can be prospective or retrospective. Yeah, really not important. And you measure the incidence. By the way, you measure the prevalence with cross sectional. That's it. By the way, in cohort, you study something called relative risk because you're studying how much risk does people who smoke, who do drug, uh, um, uh, um, like how much risk are they at of developing depression? That's it. So that's the relative risk. And of course, we will do the odds ratio and relative risk alone, but not now because it needs a lot of like calculations. So it will be on another video. Next thing is, I think we did it. Yeah. Let's now discuss the clinical trials. Just a recap on it. We'll not actually have to do all of these. So clinical trials, that's the interventional type of trials. So you intervene and again, you control everything. And since you intervene, you have to be, everything should be controlled. Everything should not be left for chance. That's the thing. Because in order to see if there is a relation, if there's a causal relation, you have to control everything because anything can go wrong. Anything can go wrong. And anything can really mess up with your data. So, yeah. And you compare, as an example, let's imagine a scenario. You compare the effect of one drug to another drug. So you compare, as an example, yeah, ACE inhibitor for the treatment of blood pressure to beta blocker, as an example, or a diuretic or thiazide diuretic, as an example. So you compare the effects of both. So you have to control the dose, control the patients, control everything. And yeah, so it's controlled. That's the first thing about it. Also, it's randomized because you can't really cheat here. No, it's not fair because, as an example, I'll tell you a way. As sometimes pharmaceutical companies, in order to make their drug work more, they will mess up with the data a little bit. As an example, they will make the more sick patients take the other drugs and make their drug, or make like a good patients, healthy patients, more healthy patients, be exposed to their drug. So already they are healthy. So they don't actually need a drug. So what they did is wrong. And yeah, you should have some sort of randomization, some sort of like a random assignments, random assigning of patients in order to make it fair. That's it. Because, by the way, in the population, the people who will take the drug, some are less sick, some are more sick. So actually, it's a randomized sample on its own. So that's the perfect sample to start with, or that's the real sample, the real life. That's it. So that's randomization. The third thing is, yeah, blinding. Again, pharmaceutical companies can mess up with the data. So we're trying to limit the intervention or limit the bad stuff. So as an example, I'll try to blind everything. I'll tell you an example. As an example, some patients, when they know they are assigned to the good drug, they get better more because they have a good mentality, and yeah, it's a placebo effect. So that's it. Some patients who know that they won't get the good drug, so they get actually less results. So the patient can't know which drug is he taking. Is he taking the placebo or is he taking a real drug? That's it. That's the first type of blinding. The second blinding is the researcher not knowing which is which. Because again, the researcher, if he's biased, if he's trying to make the drug that he thinks is better work, he will try to assign patients into the good drug and some patients to the bad drug to make his drug work. So we can't really have this. So you have to double blind. The patient can't know, and the researcher can know, both of them. Sometimes it's even triple blinding the researcher who analyzes the data, the biostatistician. So yeah, that's the biostatistics stuff. Okay, the researcher who analyzes the data can't really know which is which also in order to make things fair. That's it. Yeah, now we have three concepts actually. We have something called crossover. By the way, in order to make this also like study fair, we have to use two patients, two set of patients. Some patients who will take the drug, and some will take the other drug or the placebo. So when you're trying to compare two patients, you have to make them the same to see how will the drug alone affect it. So you're trying to do two patients with the same set of characteristics. So you will try to um, like find a copy of your patients. As an example, if you're studying the effects of like blood pressure, so you would get some patients with blood pressure, some patients with no blood pressure. Well, the thing is, you have to choose patients with the same age, same sex, same background, or ethnicity in order to make the study fair again, because all of these can affect blood pressure. All of these. So that's it. We have to limit the confounding stuff and try to make patients the same. That's it. Yeah, so there is another thing that you can do to actually go over this. I think one so again, what we did before is try to do two patients. One will take the drug, one a group of patients will take the drug, and the other group will take the placebo or the other drug. For drug one, and one will take drug two. So, and again, this group is typically or similar to typical or similar uh, uh, to group two in order to limit any founding. So we can actually do another type of type of study that actually can bypass this thing, which is called the crossover studies, because you're using the same group of patients to be their own controls. By the way, group one was the group of patients, the trial group, and the second group was that will take the placebo or the other drug. It's called the controls. Okay, so the crossover, you will make the same group its own control. The same group will be compared to the same group even, because the first group will use it. So the first group will take drug one, and then you will make something called a wash out period. That's first. So second thing is a wash out period to just get the drug out of your system. And then you will go to this same group will take drug two and then collect the data. And then you will compare the data of drug one and then drug two to see what happened. So in this crossover, you did not require two groups. You just used one group and used the two drugs on the same group. And this is good because you don't have to use a control. The control is the same group. And this actually limits the confounders because it's the same group. So it will be the same age, same sex, same ethnicity. So no confounders there. So that's a crossover clinical trial. Remember the effect of series of three treatments on the same subjects. So the subjects are their own controls. That's it. Not really important, actually. I've asked a lot. And then there's another and very, very annoying thing. I know, called intention to treat or per protocol analysis. So at first, we will have to discuss one thing, which is attrition bias. Sounds weird, but basically attrition is means lost. So sometimes patients leave your study. It can be because some of them died, so death can make you lose some patients. Some of them may leave the study because they're not, they don't agree anymore, so they leave the studies. So yeah, you can lose some patients. And losing patients is bad because at first you calculate your sample and you have to make the two groups, the one control and the one treatment group, perfectly the same. And it's calculated. So any loss can mess up your data very, very bad. So attrition is bad and it causes bias because you have missing data, incomplete data. It's not really good. So that's it. That's attrition bias. And in order to limit this thing, and to deal with attrition, we came up with two things. We came up with something called intention to treat analysis and bin protocol analysis. Ignore this one. I will not discuss it because it's not really important. And what matters is this one and this one because these are the ones asked in the NBMEs. Again, we're trying to make all of this session or all of this video one the NBME style. So yeah, intention to treat. What you'll do is as you intended to do in the first place. You will not mess up with anything. So, even though you have an incomplete data, you will still use the incomplete data as intended. So, let's imagine let's imagine here the group one, the treatment group, and this is group two, the control group. And group one was treated with the drug that I wanted to examine, and you followed them for like 1 year, and then two of them left the study, and like five of them completed the study. On the control group, you had seven patients. All of them completed the study. So you have five completed the study in the treatment group, and you have seven completed the study in the control group, and two left. And this is the attrition bias here. So what you will do is, okay, what data do I have? Okay, I have the data of five complete patients in the treatment group. I have the data of seven complete patients, like seven complete data of seven patients, and I have two incomplete. What I will do is actually I have incomplete data, but it's data. It's good data. So it has some of the effects in the year that they took. or some data from the year that they took and the year that I followed them up. So I will use these data. So all subjects, even the two that left, will be analyzed according to the original randomly assigned treatment. Everything will be kept the same as intended. That's it. Names actually are very, very important. Make sure you know this. No one is excluded. And yeah, this avoids bias from attrition. Yeah, good. And but the bad thing is it may dilute the true effects of the intervention. But yeah, it's uh, like a necessary evil in order to complete my study and complete my data. Yeah, it's not the perfect thing in the world, but the most perfect thing in the world. But again, it is what it is. So second thing is per protocol. You can do another thing. So anyone who did not complete the study will be removed. That's it. So subjects who fail to complete the treatment as originally will be excluded. But this is bad because this increases the risk of bias. Because the thing is, sometimes treatments have side effects. Not sometimes, a lot of times. So side effects. And some patients, um, and they have the total freedom to do so, uh, do not really withstand these side effects, so they leave. So when they leave, um, um, this means you have incomplete data, and this can actually hide some of the bad effects of the drug because not seeing how my drug works, I'm only seeing the five complete data that can be not showing the side effect. So I am hiding some stuff. Yeah, that's it. That's the bad thing about it. The side effects can be very severe that they made patients leave and you are not showing it. That's bad. Seems a lot bad. So yeah, bear protocol again, it's also a necessary evil, but yeah, that's it is what it is again. And yeah, that's it. That's all about clinical trials, intervention, and study types, and all of these details. And actually, we took two concepts with it: the intention to treat, which is very annoying, and also per protocol. And yeah, so intention to treat, it will tell you that all patients are included, no one excluded, all included as intended. That's it. Per protocol, no. Anyone who did not complete will be excluded. That's it. If you saw this in the case, choose as either intention to treat or birth code. That's it. Let's now have some uh, yeah, let's start. So let's start with with this first one. By the way, these questions are from Millman's PDF, complete transparency and honesty. This these questions are from his PDF on biostatistics, so you can check it out. But actually, I gathered all of the questions and I divided them um, according to the concept. So actually, it's easier for you to see the video easier than like studying the PDF. But again, it's your choice. So actually, we started at yeah. So this question here, the investigators are planning a decade-long research project on the association between CKD and long-term NSAID use. So you're trying to see a relation or a risk factor. So the risk factor is NSAIDs. These are the risk factors. And the disease is CKD. Try to arrange things as much as you can to make things more clear. So we divided to patients whether they are on chronic NSAID therapy or not, and followed them for the next 10 years. So you started with the risk factor and moved for 10 years to see will they develop the CKD or not. This seems obvious because you're starting with the risk factor, moving forward. Yeah, it's all about cohort. But we have two cohorts. We have retrospective or prospective. So this one you're moving to the future for the next 10 years for future. So this seems like prospective cohort. If it was retrospective, it would start by the electron records of these patients in the past, and then they will follow them until the present. So yeah, case control. No, you start by the disease and moving back in time retrospectively in order to see were they exposed to the risk factor or not. So you start by the disease, looking for the risk factor. Cross-sectional, no, it's in the present, and you taking a snapshot of both the disease and risk factor together. That's it. Clinical trial, it's an intervention, but there is no intervention here. By the way, NSAID is a drug, and they take NSAIDs on their own. You did not assign them, you did not give them NSAIDs. Actually, if you did give them a lot of NSAIDs, it's ethically wrong because yeah, a lot of NSAIDs can cause kidney disease, and that's actually what we're studying here. So you're not intervening anyhow. So prospective cohort here is the correct answer. That's it. Next thing is, um, actually, let's leave this one. I'll explain it at the end. Hopefully, I remember. But again, let's discuss this one. Here is a group of researchers is comparing the efficacy of conservative and operative management of acute appendicitis. Okay, 500 patients are randomly assigned to one of the two groups, 250 each. Okay, so you're either so two groups, one 250 here and 250 here. One will be conservative management, so no intervention or no operation. One operation of acute appendicitis, and then followed for 2 years. Okay, so followed for 2 years. Yeah, what do you think here? I think this is a little bit obvious. So, yeah, you compare the efficacy between two groups, and you're doing something here. You're not just standing. No, that's comparing the efficacy of two things and then following them for time to see what will happen. So, yeah, that's it. By the way, when you assign two groups to it's like controlling them and also intervening by an operation. So that's intervention. So it's controlled and intervention. So it's clinical trial. It's a randomized clinical trial. That's it. Yeah. When you see an intervention, shoot for clinical trial. That's it. And since it's not observation, it's intervention. We can cancel out everything else. And yeah, randomized clinical trial here is the correct answer. Second thing is, um, a group of researchers is trying to assess the relationship between exposure to secondhand tobacco and the development of abdominal aortic aneurysm. Okay, so you're starting the relation between the exposure to secondhand tobacco or smoking. So, and of course, smoking is the risk factor here and the development of abdominal aortic aneurysm. This is the disease. Okay, let's continue. The ultimate goal is to determine the relative risk. The study type that examined the relative risk is cohort. It's very easy. So relative risk is cohort, but odds ratio is case control. That's it. So relative risk is cohort. And in cohort, I know that you start with the risk factor and see will they develop the disease or not. But the thing is, relative risk of abdominal aortic aneurysm development in people exposed to significant amounts of smoking. They want to present the results at a conference in 6 months. So they are short in time. What kind of cohort? Because we have two kinds of cohorts. We have retrospective and we have prospective. It's same cohort. But the thing is, here we are a little bit short in time, so we need something that's quick. We don't have to follow them for years because by the way, in order to develop abdominal aortic aneurysm, it's usually in patients who are very old, like above 60. So yeah, you won't really 6 months won't be enough to develop abdominal aortic aneurysm. So you need fast results. You need retrospective cohorts using the already available data in the records. The retrospective cohort would be the answer here, and not prospective, no, needs a lot of time. And again, here you're not intervening. you will not make the patient smoke. If you made them smoke, it's unethical. So that's it. You can't intervene. It's not clinical trial. Cross-sectional, no. It's actually not taking a picture of patients who smoke and have already have abdominal aortic aneurysm. No, you will follow them in time in order to develop the abdominal aortic aneurysm. Case control, no. You don't start with the risk with the disease and go back to see the risk factor. It would be starting with abdominal aortic aneurysm and see if they did smoke in the past or not. That's it. Hopefully, it makes sense. 78, a group of researchers is trying to determine the prevalence of a disease in the population. So in the population, and I want to take a picture of the prevalence. That's it, easy, cross-sectional. Yeah, it's direct. So what studies the disease and what asks uh, how many patients have the disease, or the frequency of the the prevalence of the disease is sectional study. Easy. Again, next, researchers are designing a study to assess whether the individuals diagnosed with multiple myeloma. So this is the disease. Multiple sclerosis. Oh, sorry. So this is the disease group. We're more likely to have a history of cigarette smoking. That's the risk factor. So you start with the disease and go back in history to see the risk factor. Yeah, it seems direct. This is case control. That's it. Very easy. When you arrange things, everything actually makes a lot of sense. So this is case control and not cohort. Cohort, you start the opposite. You start with the risk factor and move forward to see will they develop the disease or not. That's it. And since here you will not make them smoke, so it's not an intervention, you're not taking a picture to see the prevalence, it's not cross-sectional, and it's not cohort. So it's case controlled. Next, a group of researchers is studying the association between radiation exposure, and this is the risk factor, and the development of AML, acute myeloid leukemia. This is the disease. Okay, so they have identified a group of patients with AML already diseased, and some similar patients but with no disease. Okay, so I start with the disease, and okay, and they were asking about the history of risk factors. I'm moving back in time to see the risk factor history or exposure history. So this also seems like case control. Very easy. Starting with the disease, moving back in time to see the risk factor. It seems like case control. In cohort, no, you will start with the risk factor, the smoking, and then move forward to see the disease will be developed or not. That's it. So it's case control here. And also, you're not making the patient smoke, so it's not a clinical trial, it's not intervention, and it's not a cross-sectional study now. Uh, um, yeah, it's the same actually question. Weird. Yeah, let's leave this one and this one. Actually, I think we are done. That's it. That's actually what you only need to know about like the case control cohort and all of these stuff. It's a very actually good practice session here. So hopefully it helped you clear these things out and made them a lot easier. So if you have any question, feel free to um, 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 comment down there. Also, if you're interested in the sessions or the focus sessions with me, you can also check my website. I'll put the link down there, and you can book a session. Also, by the way, the first session is always free, so feel free to. And the first session is like a get to know session to organize everything together. So again, thank you for watching. If you're watching, and have a good day.